years. We've got a slight experimental format this year. We tried it last year, it was very popular. Again, it went reasonably well. We will try to integrate the rationale behind the decision making within the format of a standard NHS hospital cancer MDT. I'd also like to thank Hannah, who's worked really hard to make that session very hopefully successful. And we will go through some cases, and I will be whizzing around and also interrogate some of you guys, if you don't mind. And okay, Hannah, let's start with the first case. And
so we're going to be introducing a few cases and then some integrated lecture as well. So we've got our first case, number one. We've got a 68-year-old male patient attended by the targeted lung health check. These are his past medical history. He did have some shortness of breath on exertion, but no other significant symptoms, and this was just a targeted lung health check as per guidance. His former status was 1. And he underwent the CT, which is shown in the next slide. And following on that, he had a PET scan.
Dr. Jaraman, you able to see your slide on your...
Yes, yeah, I can see it on my laptop. I don't know if anybody can see the nodules that we're meant to be looking at. There are 2 shadows on the CT scan, both of them subpleural. One is sitting on the fissure and one subpleural, the target lesion. Yeah. And the problem with the TLHC or the screening scans is that we're looking for really tiny things. Is there a point I can use? Or I should just come up here. Yeah. So this little diddling is, as you probably know, just a little bit of fluid or thickening in the fissure that's coming up. Okay. Right screen on? Yes. So it is this fellow that we are worried about, which looks subpleural, but I think that is what we're going to be following up. And I think it increased in size on the 3-month follow-up scan, which then stimulated the PET CT. I don't think there's much of an uptake on the PET CT as with these things, but thankfully it doesn't look like there's any other uptake. I've got only limited pictures here, so I'm presuming that was a very early stage tumor which we picked up, which is not even FDG habit. But again, is this a cancer? We've kind of demonstrated that there is some growth over the 3-month period, but how are we going to deal with this? Are you going to quiz our people?
Yeah, right. You're starting the MDT. Everyone's gone quiet, and they started looking at you. Can you quickly tell us what you do in 3 words, where you work at the moment, and what's your special interest, cardiac or thoracic, and then next is tell us you're just getting uncomfortable, everyone looking at you.
So I'm a trainee in Swansea cardiac.
Okay. Mr. Lott didn't turn up.
No,
MDT, so.
Not surprising. So would you like me to categorise the usual?
Yeah, okay. Well, I think is why everyone's looking at you. I think Dr. Jaraman has already characterized it good enough, and why everyone's looking at you.
Would you like me to know what to do with it?
Yeah. What else could you do trying to fend this off in the first instance? It's already sitting there, I think.
Do we have a tissue diagnosis?
Right, okay, so the answer to that question is no, because the pathologist doesn't actually get to invite you to speak about this case. And then what could you ask? Dr. Jaraman, perhaps Dr. Sutton? Okay.
By the way, I've said this is too peripheral, it's too small, it's unlikely to be diagnostic on a CT guided biopsy, so which is why you're on the spotlight.
Oh, I see.
Yeah.
It's not come up as something on our PET scan. Do we have any further imaging?
What was it after? No, it wasn't.
It was
There's no
not.
So what
evidence,
you-
we haven't got any other
And
imaging,
did
that's
we
the imaging.
did we generate a Herder score?
There were two. Yes. I don't know the Herder score for this one, this particular case, but it's going to be
1.4.
Well, you got it, honey.
Yeah, we've got it in the next slide.
Okay.
So where's Herder?
How much is taking up the glucose?
So what is that in unit then? What's the Herder in units? What's the unit of Herder?
What's the-
Right, okay. So Herder score. Any improvement on the Herder score from the? It's a score.
Yes.
Right, so it's you're gonna get. There you go. A little bit more. Oh, that's
It's a risk certification for PET. For PET.
right. So it's a stratified. What things does it consider?
The taking two things, I think to the classification of the patient and part of the nodule itself. Like the age of the patient, location of the nodule in the first hole.
So patient demographics, radiological demographics, and unique about this is the PET is integrated within that, right? So that, and how is that different from Brock? So kind of the same without the PET component to it. So you're right about considering the SUV in your scoring system, but it's only one component. All right, I think we can just now move and show what the.
So
I think the next slide has got
there's
the.
more tests in terms of cognitive assessment,
So yeah.
functions here.
That's important, right? Okay, so it doesn't take a genius to work out that this patient's lung function is okay, right? Let's move on.
So the following slide shows the patient was discussing the MDT nodule increase in size and become more solid in appearance. Her score was 1.4%.
Right. So low risk, the score, evidence of growth. What would you tell the patient's goal? Will you reassure the patient it's only 1% chance of malignancy?
Still, he was short growing, it's more than 1 centimeter, and it might be a spectrum of lipidic spectrum of adenocarcinoma, which don't show normally beta. And so discuss with the patients whether surveillance or after the diagnosis will be
Right.
necessary.
So you want to talk about surveillance, right?
And I think with this nodule is concerning.
It's 1.4.
And so
I wouldn't be concerned at 1.4%.
yeah, so possibly with tissue diagnosis and proceed.
So with the but doctor, it's 1.4%. Do you really want to cut me up with a 1.4% chance of cancer?
We can consider also a related scanning and see. So the two options I think are better.
Right, the 1.4 doesn't take into consideration growth. Okay? So the reality is, once you've got evidence of growth, everything else is pointless. Then you just either want to go and sit on it further and watch it grow, or you're going to make a decision what to do with it. We've got no other option to get histology. So that's where the conversation has to be had with the patient. So the 1.4% would have been when the first time you've done this, the Herder score, and told the patient that's 1.4, let's see where it goes. But then once we've demonstrated growth, then it's still very much concerning of adenocarcinoma. Okay, and it's not amenable. So I think we reach the end now, and I think the patient was counseled for surgery. Now, anything else we could have offered this patient? What's the next slide? Okay. Right. So let's say this patient has very poor lung function. what could we offer this patient other than watch it grow more, or yeah, you can't. Yeah, tell you it doesn't work. So you can either chop it out or saber. Can we do saber?
We can, yeah. So we need evidence of serial growth, obviously histological confirmation or a HERDA above 70%. So yeah, on this basis we would be able to save it on serial growth. It is small, 11 millimetre is small, but we should be able to save that quite successfully with 5 treatments and alternate days. So that would certainly be amenable, and the outcomes would be very similar to surgical resection for a lesion this size.
Right, so now the typical discussion in the MDT, you've got a patient like this, who possibly the ideal scenario would be surgery, and then we always tend to document alternative treatment options, and this is your real opportunity, because you're going to see the patient next, to look at your colleague who could do safer and say, you're happy. If the patient doesn't like me and doesn't want surgery, you have to have a chat with them about safer. So, because one of the consent procedures, you have to tell about your treatment and alternative treatment options. So I urge you guys, the MDT, and we don't do it often, we've got always a management plan, but we do not discuss alternative treatment options. So always have that. It's okay, if surgery is not suitable, the patient is not keen, what else there is for this patient. It could be nothing, you just have it documented. So I think the purpose of this session is really to learn the practicality of how to manage a cancer patient in the National Health Service, perhaps, or any healthcare system. Right, so...
for this case, the patient was listed for left flat low lobe resection. Station 9 was also taken, and this was the histology confirming normal resection, PT1A and naught.
Okay.